Hi and welcome to the Nurse Station. My name is Maria Mobley and today we are going to learn about chronic kidney disease. As always, these videos are for educational purposes only. I really hope they're helping you all. Something you really need to understand about chronic kidney disease. First off, there's multiple stages. It can lead all the way to end-stage renal failure or end-stage kidney disease. We are not physicians. We don't diagnose. I need you all as future nurses and as nurses that can critically think and catch things early at the bedside to understand this about chronic kidney disease. There are so many systems that when the kidneys fail, in terms of your body, that can be affected. Your heart to your lungs to your musculoskeletal. There's risk of fractures when you have chronic kidney disease. However, mind you, all these symptoms might not present in every single client. So for these NCLEX style questions, you need to focus on what priority assessment data is given to me, and therefore I will act on that problem. Don't go try to find another problem. You act on right here, right now problems, all right? So I'm gonna list everything, and I'm sure I missed something in here, but a lot of things that can happen to the body related to chronic kidney disease. And we're really gonna talk about if these symptoms present, this is your priority action as a nurse. And it's also important to understand this because when you take care of chronic kidney disease clients, which you will, you need to make sure that you can also catch things early in order to intervene and help them have optimal outcomes, okay? So, chronic kidney disease is a GFR, glomerular, I had to practice that for you guys, filtration rate less than or equal to 60 mLs per minute for 3 months or longer. And of course, remember, this is what it acts as the filter. So our kidneys need that filter in order to excrete the toxins that we want out of our body, excrete fluid that we want out of our body. We need the glomerulus to work. So as this number gets less and less and less, 60 mLs per minute is not normal. That is less than what is normal. So when you start seeing it decline, let's say they have a GFR of 50 mLs per minute, it is filtering less everything, toxins, fluids, electrolytes per minute than we need it to. So this is your primary definition. Of course, remember, there are stages and it can progress all the way to end-stage renal disease. Your causes. We already talked about acute kidney injury. I have a video on that if you have not been able to watch that yet. Of course, acute kidney injury can absolutely lead to chronic kidney disease. Diabetes and hypertension. Y'all gotta think, any organ that is perfused by vessels, which is every organ, right? We have these vessels that perfuse the kidney, diabetes, glucose starts to get built up. Isn't that gonna decrease the amount of oxygen that can get to our kidneys? There's my Picasso. But anything can build up in our vessels, in our arteries. We need oxygen to perfuse our organs. So diabetic clients can have a lot of glucose that start to build up in the lumens of the arteries that are perfusing the kidneys. Or hypertension. You know, your vessels are vasoconstricted, therefore also not allowing as much oxygenated blood to flow to our kidneys. And then infection. I'm sure when your teacher talks about kidneys or renal and urinary typically go together, you're going to talk about things like pyelonephritis. Any infection in the kidney can cause acute kidney injury as well as chronic kidney dysfunction or disease. So those are some primary causes for chronic kidney disease. And the assessment of this disease is minimal at first. You might not see any assessment data showing you that there's a problem. Their urine output could even be normal. You need to start to think about any change. You need to catch problems early because this is a progressive disease. So what we need to start looking for is the urine affected? The organ that filters water, electrolytes, and toxins, how is that starting to present in that client's body? What symptoms are starting to occur because of the lack of the ability to filter these things? So again, it can be asymptomatic at first, and then you can start having changes to urine output. Remember, in a healthy adult client, we need 30 mLs of urine per hour. Think, guys, that's one little medicine cup of urine per hour to state that, hey, they're at least filtering enough urine for this kidney to be functioning. Once you get less than that, Oliguria, by definition, is scant amount of urine, all the way to anuria, which means no urine output or very, very minimal urine output. This is the one time with these clients, chronic kidney disease, that we might not be calling the physician for urine output less than 30 mLs per hour. Because remember, we always gear you in the NCLEX perfect world, manifestation versus complication. Well, if our organ that's supposed to produce urine, right, is not working, won't a manifestation of that be decreased urine output? So a lot of times in clinical practice, when chronic kidney disease clients get to the point where they're not producing urine, that's not something we're calling the physician about. That is something that is expected with this disease, especially if they're already to the point of dialysis and other treatment options that we're going to talk about. So when we start to see the changes in urine, you need to think about, what does the kidneys do? They have the ability to excrete fluid. So when our kidneys fail, you need to look for signs and symptoms of fluid volume overload. They have the ability to excrete and maintain electrolyte and acid-base imbalances. Don't forget that your kidneys are a coping mechanism to maintain your pH in a normal range. We want the pH of our blood to be 7.35 to 7.45, right? From my acid-base imbalance videos. Your kidneys have the ability to excrete acid, such as hydrogen ion, if we're in an acidic state. Your kidneys have the ability to regenerate bicarb, to regenerate your base if you're in an acidic state. So your kidneys have so many ways that it can cope if we're having acid-base imbalances. So therefore, if the kidneys aren't working, don't you need to start looking for acid-base problems? And then toxins build up. Your kidneys are the primary filter in your body of the excretion of toxins. So when toxins start to build up in the blood, it can result in so many different things. We're going to talk about uremia. When uremia builds up in the blood, it's a toxin. It can result in change in behaviors. When all these electrolytes build up in the blood, it can result in arrhythmias, or they can have a risk of seizure. So make sure that you're looking at the assessment data for your client, because I'm about to go through a lot of body systems. However, every client is not going to present with every single symptom every time. So it's important for you on these NCLEX style questions, what assessment data is being given to me, and I'm going to find that priority problem, and then I'm going to act on that priority problem, okay? So let's start with respiratory. If your kidneys are not functioning, absolutely fluid can start to build up in the body. They can start to go into fluid volume overload. So if you're retaining more fluid, shortness of breath can occur, crackles. When you auscultate and hear crackles, fluid is now on the lungs. We don't want fluid on the lungs. Tachypnea, an elevated respiratory rate, Kussmaul's respirations, if the blood is now becoming acidic, right? So let's say that they're now going into metabolic acidosis. You can see Kussmaul's to try to get rid of carbon dioxide, which is the acid, to try to help that problem. So these are all potential symptoms that can occur. However, really think about how you could act on it, okay? You hear crackles in the lungs, we need to get that fluid off. Your medication of choice is diuretics. If they're short of breath, but their O2 sat is fine, you can't give them oxygen, but you could, if the shortness of breath is occurring with activity, slow activity or pace activity, right? If they're having Kussmaul's, we really need to be looking at that acid-base imbalances. We need to be checking our ABGs to see if there are medications we can give to help with, for instance, the acidic state that's very typical for chronic kidney disease. Cardiac. We already talked about the ability for fluid to absolutely be retained in the body. Chronic kidney disease clients can have high blood pressure. They can have edema from that fluid that is not being excreted from the kidneys. They can have risk of heart failure. So the kidneys now are not excreting water effectively. It's going to start to build up in the circulatory system. So they can have all those symptoms of edema. And now it's starting to back up, and our heart can't pump effectively. So therefore, they could absolutely go into heart failure. And all the symptoms that you learn about with heart failure can present with chronic kidney disease clients if they go into that disorder. EKG changes. Your kidneys excrete water, absolutely. They also excrete electrolytes. Your potassium, majority of your potassium in your body is excreted through your kidneys. I think it's about 80%. 80% is excreted through the kidneys and 20% is excreted through the stool. So now the organ that excretes majority of the potassium out your body is not working. Well, that potassium is going to start to build up. And you all remember hyperkalemia, or really low potassium as well, can result in arrhythmias. So we really need to be checking these clients' heart rhythms. They are building up potassium in their blood. They absolutely are at risk for arrhythmia development. So we would place them on EKGs. We would monitor their electrolytes to ensure that they don't go into arrhythmia, because if they do, we'd have to treat it very quickly. Neurologically, this is the organ that excretes toxins from our body. And now it is not coping effectively, it can't excrete effectively, so therefore toxins will start to build up in the blood. Think about any disorder you've heard about where toxins build up in the blood. Liver, I'll give you an example. Liver cirrhosis, primary example. You start to have, for instance, ammonia build up. That can absolutely result in a change in behavior. It can lead to life-threatening problems. Well, your kidneys are not filtering, so we can have a change in behavior. They can get fatigued, they can have lethargy, they have a risk of seizures. So when you think about any of those things, this all falls into safety. You need to keep the client safe with any change in behavior. Risk of seizures are very different from active seizures. Risk of seizures is safety because they haven't seized yet. So you need to think with any risk of seizures, or let's say risk of arrhythmia development, your priority is to keep them safe. We can place them on seizure precautions. They can be on medications around the clock to assist to prevent seizures. Then you have hematological in skin. Your kidneys create and help the bone marrow form red blood cells through erythropoietin, the hormone that is needed for red blood cell formation. So now the organ that is in charge of that hormone is not working effectively. So we really have to look for signs of bleed. You need to look for ecchymosis. You need to look for anemia. You need to be looking at their CBC, their complete blood count, to see if they're starting to show signs of anemia, or let's say their hemoglobin hematocrit levels are going low. Their platelet counts are going low. We need to catch all those signs early to try to assist them from an active bleed, to try to prevent that. The skin. We talked about the toxins building up in the body. Urea, which is a byproduct of protein metabolism and other things being metabolized, needs to be excreted from the body, right? So it's a toxin if it builds up in the blood. When you start to have that build up, it can absolutely cause skin irritation and dryness. It can start to form at very late stages. It's called uremic frost, which looks like little crystals or particles on the skin. Well, chronic kidney disease clients can absolutely have a problem with dryness and irritation of the skin. A lot of scratching and itchiness can occur. So they can be placed on medications to reduce that inflammation and to reduce the itching. So look for those signs of bleed. Look for the changes in skin. And then musculoskeletal. We're about to talk about electrolytes in 1 second, how our labs will look for a client with chronic kidney disease. And one of the electrolytes that affected is calcium. So when the kidney fails, it cannot excrete potassium, we've already talked about. Clients get hyperkalemic. It can't excrete phosphorus. Clients become hyperphosphatemic. Well, you got to remember, phosphorus and calcium are inverses of one another. So if a client in chronic kidney disease has high phosphorus, the inverse would be that they have low calcium. And remember, we want calcium to be in our bones. Calcium helps to create strong bones. It helps prevent and reduce the risk of fracture. So when they have hypocalcemia, they absolutely are at risk of fractures. They're at risk of weak bones. So again, we'd have to protect the clients from fractures. So there's a lot of potential symptoms that can develop and occur with chronic kidney disease. It is your priority to look at these symptoms and think about which one will kill them first. So I'll give you an example. You have a client who has, I'm going to underline a couple things so we can see how we're critically thinking. You have a client with shortness of breath, you have a client with crackles, and let's say you have a client with lethargy. So let's label these according to Maslow's. Shortness of breath, is that right here, right now breathing or risk of breathing? And if you say right here, right now breathing, you're correct, but I'm going to ask you, do you know their O2 sat? They could be short of breath and their O2 sat could be just fine. So can we necessarily act on this by giving them oxygen? No, you cannot give a client oxygen without knowing their O2 sat. They could be short of breath and their O2 sat be just fine. I'll give you an example, a COPD or chronic obstructive pulmonary disease. They are short of breath, especially with activity. But when you check that pulse ox, it could be just fine, okay? So shortness of breath, the only thing you can do is maybe stop activity. If it is associated with activity, you could raise the head of the bed if the head of bed is flat, but you cannot give this client O2 yet. Let's think about crackles. Can you act on crackles? Crackles now means there's fluid in the lungs. And remember, in these NCLEX style questions, if you have an answer choice to give a medication, it is assumed you already have the physician order to do so. When we have crackles in our lungs, fluid that should not be in our respiratory system, can you act? Absolutely. You need to diurese them right here, right now, or you need to do a fluid restriction. You need to do something that will help reduce fluid in the body to help prevent and get rid of that fluid, especially from a place that's not supposed to be, your lungs. So you can absolutely act on crackles right here, right now. Between shortness of breath and crackles, crackles is your priority, all right? And let's add lethargy in it. Lethargy is a change in behavior. They're very tired, very fatigued, right? Would that change in behavior ever trump fluid that is right here, right now on our lungs? It would not. You would keep these clients safe, but between this assessment data, the one you should have acted on, the one that would be your priority, are the crackles, okay? So that's just a little critical thinking. And get together with friends you study with. Pick out assessment data and see which one could you act on right here, right now, or which one do you have to gather more data for. Because in chronic kidney disease, you fix right here, right now problems first, according to Maslow's. So between diuresing the crackles in the client, diuresing the client that has crackles in the lungs versus trying to find a pulse ox for the client with shorter breath, do you understand you're trying to find a low O2 problem, but you have a right here, right now fluid on the lung problem. This is the one you need to fix first. That's critical thinking. That's Maslow's, okay? So really look at the assessment data that the chronic kidney disease client is presenting. Find the priority one, and that's what you should act on in these NCLEX style questions. So now let's talk about our labs. Of course, we have kidney dysfunction. So the labs that should always pop to mind for you are BUN and creatinine. You will have elevated BUN and creatinine levels with kidney dysfunction. Look for azotemia or look for the toxin buildup in the blood, right? The urea, because we need to monitor for the change in behavior. We need to monitor for other associated problems that relate to toxin buildup in the blood. Decrease glomerular filtration rate. You already know that because that meets the criteria or the definition for chronic kidney disease. We already talked about anemia because your kidneys excrete erythropoietin, so they can have low hemoglobin, low hematocrit levels, and a lot of changes in electrolytes. So remember, kidneys are the primary source to excrete potassium from your body, and now is not working effectively. Hyperkalemia, potassium starts to build up in the blood. Hypermagnesemia, again, magnesium starts to build up in the blood because the kidneys aren't excreting magnesium effectively as well. Along with hyperphosphatemia. So your three elevated electrolyte levels: high potassium, high magnesium, high phosphorus. And remember, phosphorus and calcium are inverse, so therefore that's why you have hypocalcemia. So really, really remember these electrolyte levels, because a lot of our treatment that we're going to talk about on the next side of the board is related to the symptoms that develop in the labs that present for clients with chronic kidney disease, okay? I did not put sodium on here. Sodium could be normal. Sodium could absolutely be normal. Sodium could be showing signs of fluid volume overload, but just because of the body's ability or inability to excrete fluid effectively, a lot of chronic kidney disease clients you see on a low sodium diet because of that fluid volume overload that may present. So sodium I did not put on here. Typically it can be normal. If they are holding on to way too much fluid, it could be diluted. So it just depends on the symptoms the client is presenting with. And then acid-base imbalances. Your priority acid-base disorder you need to look for is metabolic acidosis. This is not a breathing problem. We are not going to talk about respiratory anything. You can have Kussmaul's respirations, which is a coping mechanism by the body. But when you think the kidneys, you are thinking a metabolic problem. And the metabolic problem you're going to think about is the inability of the kidneys to excrete acid effectively. So remember, toxins build up in the body with kidney failure. Well, now you're going to think acid is going to build up as well. So they are at risk of metabolic acidosis. So the pH would be low, would be less than 7.35, and your bicarbonate levels would be low as well. They'd have low base. You need to monitor for infection for these clients. So look at their white blood cell count, look for fevers, look for any signs and symptoms of infection, because of course they're compromised. And we already talked about fixing right here, right now problems first. Let's do another one. How about, let's say, GI bleed, risk of seizures, and tachypnea. 3 problems, all right? This will help assist with critical thinking. So let's label them. Tachypnea is elevated respiratory rate. But again, I ask you, can you prove what their O2 sat is? Can you prove the oxygen in their body? You can't. Tachypnea, you can't even put oxygen on them yet. The first thing you would have to do is assess their pulse ox. So we're not going to be able to act on that right here, right now. Risk of seizures. Again, risk of seizures means they have the potential to seize, but they're not seizing right here, right now. So your topic for risk of seizures is safety. And then you have GI bleed, which is a right here, right now, circulatory problem. You should pick circulation over safety every time. So between these 3 problems, your priority is GI bleed. You need to start intervening for bleed. You can give them fluids, you can give them blood products. You can give them other medications to assist to reduce bleed or to replace volume, okay? So look for all those things, but again, I really want y'all to harp on finding the right here, right now problem that will kill them first, according to Maslow's, and that's the answer choice you need to gear yourself towards. So let's talk about treatment options. A lot of treatment options for a client with chronic kidney disease. First things first, you have to treat the trigger, if there is one. For instance, if pyelonephritis, infection of, which is a kidney infection, if that is the trigger that caused chronic kidney disease, you need to treat it. You need to give them antibiotics. Let's say it was acute kidney injury related to a urinary obstruction. Let's say they had a stone in their ureter. Well, you need to ensure to get that stone out or to allow for them to excrete that urine one way or another. So always treat your trigger if there is one. And then your nursing interventions and evaluation. So now we're going to go back through each system. We're going to talk about what we can do for the problems that we mentioned in our assessment data. And then also we need to think about how do we evaluate once we intervene on those problems to see if those problems got better, okay? So, starting with your respiratory system. Oxygen as needed, of course. If you ever see a low pulse ox level, you ever see a low PaO2, low arterial oxygen, your priority is to give oxygen. Positioning as needed. That shortness of breath, let's say they were short of breath while laying flat in bed because they have too much fluid on them. You need to sit the head of the bed up. And then respiratory support as needed. Y'all need to, as always, certain diseases, and really any disease, can cause the client to decompensate. It might get to the point, end-stage renal failure, that they no longer can breathe effectively on their own. They might need to have an endotracheal tube placed, an ET tube, and we might need to mechanically ventilate them for them. We might need to breathe for them. So respiratory support as needed, and just look for that assessment data in your NCLEX style questions. If they get to the point where they no longer can breathe on their own, we will assist them to do so, okay? Cardiac, EKG monitoring, we need to look for arrhythmias. We talked about potassium. Potassium absolutely can cause arrhythmia. Hyperkalemia can cause arrhythmia. But don't forget all the electrolytes that help stimulate and maintain an electrical impulse in the heart. Potassium, magnesium, calcium, and sodium all help to allow for that electrical impulse to be conducted effectively. So yes, look for hyperkalemia. Place the EKG monitor on the clients to ensure that they're not in an arrhythmia. And if arrhythmia develops, you will have to treat that arrhythmia dependent on what type of arrhythmia it is. So EKG monitoring, controlling of blood pressure. Their blood pressure can be so high because the kidneys are not excreting fluid and toxins appropriately. So clients with kidney failure can be on antihypertensives. They can be on beta blockers, calcium channel blockers. They can be on ACE inhibitors, ARBs. They can be on a lot of medications to help reduce blood pressure. Controlling of fluid volume overload or maintaining fluid volume overload. So whenever you think about a client that is holding on to way too much fluid, edema, jugular vein distension, crackles auscultated in the lungs, you need to get that fluid off of them as quickly as you can while maintaining their stability. So fluid volume overload can result in diuretic administration. You can see furosemide, aka your Lasix given. They can be placed on sodium and fluid restrictions. So they could be on a sodium and fluid restricted diet if they're having signs and symptoms of fluid volume overload. And then monitoring vital signs, monitoring INOs, monitoring daily weights, and heart and lung sounds. In order to catch these problems, you've had to assess their respiratory and cardiac status. Blood pressure, you need to be monitoring their vital signs on a routine basis. Daily weights, we need to see, are they gaining too much weight on a daily basis? And we need to report weight appropriately. Majority of your resources say report a weight gain of 2 to 3 pounds in one day or 5 pounds in 1 week. So that is how we would monitor. If we're given a diuretic, if we're given furosemide, we want to see that they're losing weight on a daily basis because that means they're actually effectively getting rid of fluid. If you give a diuretic, you want to auscultate lung sounds. Because if you hear crackles, how you know a diuretic is working is not by the urine output. Diuretics increase urinary output. We want to know whatever the problem was. We hear crackles, you administer furosemide, we want to auscultate clear lung sounds. That's showing effectiveness. That's evaluating that our treatment's working. So all these things right here is just a way to assess and evaluate, is our treatment working? Neurologically, you need to keep them safe. They have a change in behavior. You need to ensure that they're not trying to get out of bed by themselves. It might even get to the point that they need a sitter at the bedside. If they're at risk of seizures, you might need to place them on seizure precautions, padding the side rails, having sections set up at the bedside. So when you think neurological change or risk of seizures, you need to keep them safe. Hematological, we already talked about how we need to monitor for bleed. GI bleed can absolutely occur with kidney failure. Think about your anemia that can occur. So monitor their CBC. Hemoccult stools to look for that GI bleed. Epopoietin alpha, we can administer the hormone. We can give iron replacements. We can give blood products as needed if anemia or bleed is a concern for our clients. Skin, avoid irritants, avoid scratching at the skin. Antipyretics can be administered to help calm the itchiness, to help calm the inflammation that can occur, especially related to that urea that's built up. Risk of infection. Monitor for signs and symptoms of infection, and of course, as we would do with any client, we need to maintain asepsis with procedures. We need to make sure that any invasive procedure that's done, for instance, a client could be a candidate for dialysis. Well, accessing the fistula or the perm cath, or making sure that everything is being maintained in a sterile fashion. Even the dressing for a perm cath, when we talk about hemodialysis and peritoneal dialysis in another video, needs to be maintained in a sterile fashion. So really maintaining asepsis with invasive procedures, monitoring for those signs of infection, and all your labs. We have so many medications we can give for abnormal electrolyte imbalances. So we're going to start with potassium. High potassium, of course, we'd monitor their heart rhythm, but let's think about the medications that can help reduce potassium in the blood. Sodium pyralestrine, aka K-exalate, helps bind to potassium so it can be excreted from the body. Loop diuretics, of course, furosemide is a gold standard for excreting potassium along with other electrolytes from the body. IV regular insulin. When you give insulin, and this is IV insulin, IV regular insulin, to a client, it helps to push potassium from the blood. So here's my potassium in my blood back into the cell, okay? But remember, especially if they're a non-diabetic client, if we're giving IV regular insulin, we of course would always monitor blood sugar checks, blood glucose checks to make sure that we're not causing hypoglycemia, but you might need to be given dextrose along with this to ensure that we don't make them bottom out in terms of their glucose. So we can give IV regular insulin, we can give calcium gluconate to help prevent arrhythmia formation. In terms of increased magnesium, our gold standard is loop diuretics. Again, furosemide is a great thing to help reduce potassium and magnesium in the blood. Increased phosphorus, you need to think phosphate binders. Medications that will bind to phosphorus and excrete it, or because phosphorus and calcium are inverse of one another, if we have high phosphorus and low calcium, we start to administer calcium and calcium starts to increase. If they are inverse of one another, what's going to start to happen? This will start to decrease. So all these medications are either phosphate binders. Your Selvomir, of course, is a phosphate binder. And also we have the ability to give calcium because it's inverse to help bring down those phosphorus levels. For low calcium, you of course would do calcium and vitamin D supplementation. You would protect them from fractures. You would increase activity, especially weight-bearing activity, to try to help push the calcium that we have back into the bone and prevent fracture. So with low calcium, you give calcium and vitamin D supplementation. And then low pH. If we are in an acidic state, typically when you address the trigger, it helps resolve pH balances. But we have the ability to give sodium bicarbonate, which is a base, when we are in an acidic state to try to help improve acidosis. And then your diet. We need to think low protein diet. Your body's organ that helps filter toxins is not working effectively. And a lot of toxins are created from the byproduct of protein metabolism, okay? So we need to have a low protein diet just because the components that protein breaks down into may not be able to be filtered from the body effectively and then builds up as toxins. And then you also have to think about what electrolytes are being presented at this time. If they are hyperkalemic, they need to be on a low potassium diet. If they're in fluid volume overload, they need to be on a sodium restricted, fluid restricted diet. So also think about what other assessment data is being presented. And then of course, last but not least, dialysis is absolutely a potential option for clients in chronic kidney disease. It depends on the GFR, it depends how much the disease is progressing, but dialysis is a potential option for these clients along with kidney transplant. So be on the lookout for a dialysis video that differentiates hemodialysis along with peritoneal dialysis. But I think the big takeaway from this video is you can see how many different symptoms can present with chronic kidney disease clients. But it is your job as a nurse to catch them early and also intervene on the priorities. So please remember and ingest this knowledge, but also think about how you're going to best break down those NCLEX style questions. So I hope this helped. We are better together, nurses, so help someone else. And good luck on those tests.